Today, I'm joined by Miss Nishani Amerasinghe, consultant ophthalmic surgeon and glaucoma specialist, and a previous president of the United Kingdom and Ireland Glaucoma Society. Nish has spent over 2 decades managing complex glaucoma and cataract patients, often over many years, which gives her a very different perspective on outcomes, risks, and decision making compared to high volume cataract practices. She's also an early adopter of 3D heads up microscope surgical systems. Nishani, great to have you.
Thank you for the invite. It's a pleasure.
Nish, perhaps we could start by you telling us a little bit about your consultant career to date. Tell us what you've been up to.
All right. So I started off probably in about 2012 as a consultant at Worthing and Chichester. It was a great place to start a consultant job. Introduced me into it, but it was a little bit of a small department for me. So, and I trained in sort of complex glaucoma, and they had two big units with Brighton and Portsmouth on either side. So, there wasn't a need for a complex glaucoma surgeon. So, when the opportunity came up for a job at Southampton, I took it. I jumped at it and took it. So now I am mainly complex cataract and tertiary quaternary glaucoma. A lot of very complex cases from the South Coast and the Channel Islands and as far as the Falkland Islands sometimes. So it's a very interesting, complex group in the NHS. I do also do private practice on the side, and those patients are probably less complex, but it's a more sort of manageable practice for me, and I enjoy that side of things as well.
Are there any particular issues that you have to face with your island patients? I mean, people flying in from the Falkland Islands for something fairly complex to be done. Often it's the work that you do after surgery that's just as important, isn't it?
Exactly, and that's something that you'd have to kind of really counsel the patients on, because I think they all have this sort of idea that they're going to come in, have their operation, and then go home and then get looked after there. And I have to tell them that no, actually, you're either going to have to stay on the mainland, or you're going to be flying backwards and forwards, having procedures done and lots of post-op follow-up, and managing that mindset is a bit of a skill.
Absolutely. Now, glaucoma forces you to think in terms of decades rather than days, doesn't it? Has
Mm.
your involvement in glaucoma changed how you view cataract surgery and outcomes?
Yes, I mean, glaucoma surgeons do all we get the more complex cataracts. So I think we approach cataract surgery in a completely different way. We are thinking about that long-term outcome, what it's going to do for the glaucoma, what it's going to do for any surgery that we might need to do in the future, or what we've done already in the past. So we're looking on a very in a different way, in a much more long-term management of the patient. I mean that's the beauty of glaucoma. Also can be a bit of a downside, is that those patients are with you for life. So you have a big relationship with them, and so you need to manage expectations of the patient for the whole of their life.
And of course, it can be an upside having them for life
Yeah.
as well, can't
I
it?
mean, you have that relationship with the patients, and that, they are lovely. So, you get to know them really well. They get to know you as well. I'm always surprised at how much they remember about myself and my children and all that sort of stuff, and then they'll bring it up suddenly 4 or 5 years down the line. So yeah, no, it's a real benefit as well.
And do you find yourself counselling patients an awful lot about the fact they've got quite bad glaucoma as well as cataract? Because their outcomes are going to be profoundly different compared to their neighbours having simple cataract surgery, aren't they?
Oh, definitely, and it is about managing expectation, and sometimes, and changing the mindset. So their neighbor will have gone in, had a 20-minute operation, and come back out and have been absolutely fine, and there's been no bother, and they're not seen again. Whereas with the glaucoma patients, you've got to really counsel them that this is a long-term process, and a lot of the time, actually, with the glaucoma operations themselves, that they're going to be heading for those operations in a couple of years' time, maybe. So you're sowing the seed about the fact that they are going to be heading for surgery quite early on. And you also sow the seed that actually you may be needing to do their cataract operation before you do the glaucoma procedure. And then they can go away and uh, think about it, read about it. By the time you've actually got to the stage where they may need surgery, and because they need surgery like a filtration operation, trabeculectomy, you might be doing their cataract beforehand. They've already kind of mentally known that this is going to happen, and so it's far easier to manage the expectations of it.
Now, MIGS, microinvasive glaucoma surgery, has been widely adopted. Where do you think it genuinely helps, and where has enthusiasm outpaced evidence, if you like?
I think I'm a big proponent of MIGS. I think it is not the cure for glaucoma. There's no doubt about that. But however, it has been shown to be effective, and it's shown to be safe. So it is a can be used as a bridging procedure before bigger filtration surgery is done. Doing it with cataract surgery is the main opportunity to offer it to the patients. But again, you're managing patients' expectations. It may not. What is a good outcome for that patient, and that's something that you need to discuss with the patient. And having grown with your glaucoma patient, you know what their needs are and what their expectations are. So for one patient, it might be we're taking you off the drops, and therefore giving you a better ocular surface at the time of your cataract operation. For another patient, it might be lowering the pressures. Usually it's not really done just to lower the pressures. It might be improving compliance because you've got them off the drops. So there's lots of different things that MIGS can different outcomes that MIGS can offer to the patient, but you've got to manage their expectations. And for other patients, for the advanced patients, you may be doing a trabeculectomy operation or some kind of filtration operation down the line, and you're doing their cataract beforehand so that it doesn't develop later on. And then when you do the cataract operation, causes the filtration surgery to fail. Actually, you're going to do this cataract, so do you offer them a MIGS device so that at the same time, so that you bring them off some of the drops, and then their ocular surface and their conjunctiva is far better for when you do that filtration surgery. So using it as a sort of bridging treatment is another offer. But there are lots of outcomes from MIGS, and it's choosing the right outcome for the patient at the time.
What about your views of using premium lenses in patients with glaucoma? Torics, EDOFs, multifocals, all of the above?
I think we want to give our patients the best outcomes, but glaucoma is a disease that affects your contrast sensitivity. I'm not a proponent of using EDOFs, multifocals in these patients. I think there may be an opportunity with the enhanced monofocals, but even those I'm not sure about in very advanced glaucoma. I don't really offer it I don't offer any premium lenses to any of the glaucoma patients in my private practice.
Even torics, out of interest?
Torics I do offer, yeah.
Yeah. Moving on, you've been a very early adopter of 3D surgical systems. We discussed this at length about a month ago. Mm-hmm. For everyone else's benefit, what convinced you to use this in your practice?
So I wanted to try it to see what or what the visualization was like. There are benefits from a kind of ergonomics point of view, especially with the MIGS surgery. You do need to tilt the microscope, but you don't have as many problems and as many steps to get that really good gonio view. And with the system that I use, which is the Alcon Ingenuity 1.5, the newer Ingenuity system, they have their own MIGS angle-based visualization, which is absolutely brilliant, and you get really good visualization of the structures. So from that point of view, for angle-based surgery, I think it's really good and something worth trying. I think there is some downsides to it because of the way the system is and how it has to be set up. That for MIGS surgery that we're doing on a regular basis, temporarily usually, it's quite bulky to change these systems around, and that's the biggest downside I see.
Can you foresee a situation in the future whereas rather than having a giant TV screen opposite, you simply wear a virtual reality headset instead? Would that allow you all the advantages without the disadvantages, the ergonomic difficulties you described?
think if you've got the vision completely, the image quality completely right, it could be done. And you'd obviously want the rest of the team to be having a similar image so that they know what's going on, either the assistant or the scrub team. But I suppose it is an option, possibility.
I think there might be something on the market, but I'll have to go back and research that one.
See what see what the image quality is like.
And do these 3D systems, do they actually improve patient outcomes, or is it really about the surgeon experience?
I think it probably is more about the surgeon experience, though if you are, able to visualize the angle in a much, in a far easier way, your ability to place these devices is going to be much better.
And what about your experience with these systems and cataract specifically rather than angle surgery?
So with the cataract surgery, I mean, I always do the cataracts most of the time when I'm doing the MIGS procedures, I'm doing cataract surgery beforehand. I do find it, I mean, I don't find any difference there. I think when you start out, your ergonomics are slightly different. So it's just getting used to that, but that doesn't take very long. And, my trainees do it easily when they start out. There are different modes that you can use, especially for these glaucoma cataracts, where they are usually denser cataracts, usually using vision blue. So there's the capsule imaging mode so you get better visualization with these. So I wouldn't say I would say that with the angle-based imaging, it is better. You get a beautiful view. I don't think I see a very big difference between doing cataract down the microscope and cataract on the 3D visualization, apart from obviously the ergonomics of sitting.
And when you've had trainee surgeons working with you, do they tend to get on with the system better than us oldies?
I think they do.
Yeah.
Definitely. They just seem to just sit down and get on with it, and they're already set up, and they can see, they set themselves up. It just seems so much more intuitive to them. Whereas when I started, I was very much like, now move it up, move it down. Oh no, I'm in eye level. No, I'm not, until I got to this position. Because I think the other thing is that we're so used to being hunched over the microscope and a slit lamp when our natural positioning isn't that great anyway. Whereas they just sat down and got on with it straight away. They found it very easy from that point of view.
Training in general, moving away from the 3D microscope, you've trained an awful lot of surgeons over the years. Does anything concern you about how we're training surgeons and ophthalmologists now?
I think I do worry about competencies and the numbers that the trainees need to kind of get through the system. And obviously the training has become more concise. I mean, but if you compare that to other training systems around the world, in Singapore, Europe, we've had one of the longer training systems, but I've always thought that's a benefit. I've never thought that you should kind of cut your training as short as possible and not do a fellowship. I think you're a consultant for a very long time, and actually trying to get to consultant jobs as quickly as possible isn't really the way ahead, because you'll get bored as a consultant unless you're constantly changing your focus, and we have to do that, otherwise the job wouldn't stay interesting. So I think enjoy your training time, and keep it as long as you possibly can, from a feasible, as feasible as that can be.
I couldn't agree more. There's an old analogy that with learning to drive a car, you only really learn to drive once you've passed the test and you're out on the road on your own. For yourself, Nish, at what stage in your career do you think you developed that mature judgment that we all know you for now? Was it before you became a consultant or considerably after you became a consultant?
It would have been definitely after. There's so much that you don't learn, that are subtle and kind of difficult to teach, um, and that you don't get until you are a consultant. However, having said that, I think you want to be trained to the best of your ability before you become a consultant. When you start out as a consultant, that you think you get that sort of confidence that you can do it all because you clinically trained yourself to be the best. And that's what you should aim to do. However, when you kind of jump into the consultant world, you realize it's not just about your clinical training. There's a lot more around that. And actually, I think the benefit of fellowships is not just learning about how well you can be and how complex these cases are and how you can manage them. It's also watching consultants at the top of their field navigating all the other issues that you have as a consultant, and also getting mentors that are always that you trust and that are available. You trust their advice and judgment that are available for you when you're a consultant. Phoning a friend is always a really good deal, I think.
It's better than asking the audience a lot of the time.
Yes.
So, I mean, a lot of us have had imposter syndrome over the years. Did you ever have that when you started out?
I still have it.
I'm sure that's not the case.
Yeah, I mean, I think you always will to a point. But again, I think colleagues, knowing that you've trained well, I do think the benefit of surrounding yourself with people that you trust and trust their judgment of. When I say surrounding yourself, I don't mean like physically they have to be in your department all the time or anything like that. And sometimes they don't even have to be in ophthalmology, but they will have an experience in the world of medicine, whether that's managerial side or clinically, but giving you a different view on things really helps you in your career and it helps you maybe reduce that imposter syndrome.
So, what do you think separates a technically good surgeon from a truly great surgeon?
Insight, probably, and an understanding that you're not always going to be able to do the ultimate best operation or procedure for a patient, but by managing expectations, counseling patients, you will be able to take them through a journey that might not seem like you've got the best outcome at that point in time, but probably what you want to be able to do is over a period of time be able to look back and go, yes, I did the right thing. And if it didn't come out quite right at that point in time, that was actually the right thing to do.
In glaucoma, sometimes the hardest decision is not to operate or not to intervene. Do you think that restraint is undervalued at times in modern ophthalmology and modern medicine? We're often compelled to do things, aren't we?
Yeah, no, I think you are compelled to do things, and I think that's patient expectations are also there, and I think that's something that as a junior or even as a senior fellow, you think, well, I can do this operation. Why are we not doing this operation scenario? Having the confidence to say that actually the eye's been through enough already comes with a lot of experience and a lot of confidence and understanding about the disease, and being able to explain that to a patient. And usually, again, if you've taken that patient on the journey with you through their management, they're coming to the same conclusions as you are because you've sown those seeds along the way.
So, with NHS backlogs and the pressures that go along with that, do you ever feel pushed towards decisions that prioritize flow over nuance, should we say?
I think yes, but one thing I don't want to do is compromise on the time patients need. So my clinics famously finish really late. I think especially with a chronic disease like glaucoma, but also chronic complex glaucoma requires surgery where the outcomes aren't you're going to be better. The outcomes are going to be stable. Stable is good in glaucoma. That's about it. And a lot of the time you could be worse as well. There's a significant risk that you could be worse. Therefore, you need to really take your patient on board with that journey, and that does take time. And this is our constant head banging against the wall about, numbers that maybe, managers have to deal with and show. If we're taking out all our low risk glaucoma patients, well, the ones that are left behind take time, and we can't see the same numbers. And if you want to see us to see the same numbers, the clinic's going to finish really late. That's where we're at.
Do you ever get that familiar argument from the managers about improving your new to follow-up ratio?
Not so much anymore.
Good.
I think they understand that now, but yeah, we do have a bit more of a numbers problem.
Moving back to cataracts, Nish, obviously this isn't the case, but if you were to need cataract surgery yourself tomorrow, what lens would you have implanted in your own eye and why?
I think I do have quite a strong family history of glaucoma, so I think I wouldn't go for anything really fancy. Definitely want a hydrophobic lens, but I think I'd probably just go for something quite simple and just have the best clarity of vision with glasses if need be, to be honest.
And would you want your surgeon to be using a heads-up display like you do?
If they're comfortable with it, I have no problem with that.
And what would you be looking for in your own surgeon?
I think that, well, obviously they have to be technically good at cataract surgery, and you'll get that from reputation, and we're a small world, we know, and most people are very well trained at the top of their game. I think what I want is that insight and that ability to have a proper conversation about the surgery and about the lens choices.
Looking around the country, is there anything that you see your colleagues, our colleagues, doing that you quietly disagree with, that you rarely challenge?
It's not that I don't challenge it, because I think we are trying with this. I think this whole mixed debate about whether glaucoma patients should be offered MIGS is a hot topic. And I do believe that conversation should be had with that glaucoma patient undergoing cataract surgery. I'm not saying that every single patient should have a MIGS procedure, but in the same way that we discuss the ability to have premium lenses with our NHS cataract patients, that there are other lenses out there. I think that the discussion about MIGS should be had with all glaucoma patients undergoing cataract surgery.
Makes a lot of sense. And Nish, final question. If you weren't an ophthalmologist and glaucoma and cataract specialist, what would you be doing instead?
Oh, gosh. Well, two things. When I was younger, I always wanted to be David Attenborough, so I always wanted to be a naturalist. Didn't actually quite go for natural sciences in the end. Went for medicine. And two, the choice between ophthalmology and the other one was psychiatry.
Well, as we film this, fortunately, there's no vacancy for David Attenborough's job. It's a good thing.
Yes, exactly. Done a far better job than me.
Nishani, thank you so much for joining me.
Pleasure. Thank you.